Right, welcome back, everyone. Let's dive into our second presentation, gluten in celiac disease research, when, why, and how. Dr. Daniel Leffler is a practicing gastroenterologist caring for patients with celiac disease and other gastrointestinal disorders. He's a founding member of the Celiac Center at Beth Israel Deaconess Medical Center in Boston. He's also an associate professor of medicine at Harvard Medical School, where he continues to see patients with gluten-related disorders. Dr. Leffler has been the recipient of multiple National Institute of Health and foundation and industry-sponsored grants for the advancement of digestive health. Dr. Leffler joined Takeda Pharmaceuticals in 2016 as a medical director and the global clinical lead for celiac disease in the gastrointestinal therapeutic area. For those of you who have been to our conferences before, you might recognize Dr. Leffler's name and face, and we're thrilled to have him back. Welcome, Dr. Leffler, and please go ahead.
Thanks very much, Mark. And thanks, everyone. Always really enjoy my times working with the CCA, who continues to be such a progressive and forward-thinking organization. So let me share my slides. Hopefully this will come up well.
Yes, we see it.
Excellent. All right. So I chose for this topic gluten and celiac disease research, when, why, and how. Some of this gets a little technical, but I actually have not too many slides. I learned from last year where there were so many good questions we didn't get to. So my goal for this presentation is to sort of keep this high level, provide an overview of celiac research and why we still use gluten in it, and then have plenty of time for questions. And of course, as always, those questions can range clinical topics or what I've been talking about in this talk. So first, my disclosures, as Mark just mentioned, I do work for Takeda Pharmaceuticals, working to advance therapies for celiac disease. I also serve on the committee for the Foundation for Celiac Disease Outcome Measures. So I wanted to start with some background, and actually I thought the way to do that might be to start with my conclusion slides from my last presentation at CCA. So I will forgive you if you don't remember exactly what I talked about last year, and hopefully a lot of you are sort of repeat customers. But last year I talked about the future of celiac disease research and where I think I see us all going on this journey together in celiac disease, and how much we've learned. A lot of this Jocelyn just touched upon. Celiac disease is present in virtually every population, as she mentioned. And a lot of what I talked about was around the limitations of the gluten-free diet, which again, Jocelyn just mentioned, where even in Europe, which I think in general we can think of as the most advanced gluten-free community, gluten exposure is still common and disease control is not frequently achieved. Histologic recovery, as Jocelyn again just said, very slow and partial, and in a way that we don't allow for other diseases. I mean, if you look at, reflux esophagitis, when people have acid reflux and damage their esophagus, we don't think it's acceptable to say, oh, maybe in 2 or 3 years your esophagus will heal, right? That's just something we do in celiac disease that I hope will change in the future. We also don't have great ways to monitor celiac disease. Blood tests are great for diagnosis, not so great for monitoring, leaving us only with endoscopy, which obviously we don't want to do all the time. And my conclusion was really that I think novel therapeutics, whichever one makes it to the forefront, and I think there's a lot of exciting ones coming, will really change the way we treat celiac disease globally, and really start to think about it in the way we think about a modern immune disorder, where we look at different measures and really aim to achieve better disease control across the overall population. So this was actually my closing slide from last year, and it still remains true. That there's no immune-mediated disorder that has a single accepted treatment, other than, of course, celiac disease today. Celiac disease is a heterogeneous disorder, and different therapies and combinations of therapies will likely be needed to optimize health and quality of life. However, the main thing holding us up is not interest from the medical community or even funding these days, although funding is still an issue. It's slowly been improving over the last decade or so, based in part on work from the advocacy groups, including CCA. But we're really desperately in need of research participation. And I'm going to make the jump, but I don't think it's a big one, that everyone on this call is here because we care about celiac disease. And if we care about celiac disease, then we want it to progress, right? We want to learn more about celiac disease. We want better tools. We want the next generation's life with celiac disease to be even easier and better than this generation's is. And I think we've seen great improvements from what the last generation had for celiac disease. So I think we all have a vested interest in seeing celiac disease continue to progress. And the way to do that is obviously with research, right? There's no way we can progress celiac disease, progress our understanding, develop new tools, develop new therapies without research. And research, we do what we can with test tubes and things like that, but really it requires people. And so the biggest hurdle today in celiac disease making progress is research participation, is getting more people and more diverse people, really importantly, to participate in celiac disease research, because we know celiac disease presents in different ways. There are probably some subtle differences in different ethnicities and how they present with celiac disease and how some of the blood tests work in celiac disease. And so we really need more widespread participation. And I've given this type of a sort of pep talk for celiac research a number of times, and everyone's all excited, they raise their hands, sign me up. And then we say, but we'd like some of you, if it's okay, to think about taking gluten as part of the study. And suddenly it turns into sort of like you feel like you're in an elementary school when the teacher asks a tough question, everyone starts looking around at their shoes or out the window, pretending they're somewhere else, right? So I thought maybe this time I'd really spend some time talking about why we still use gluten in celiac disease research. And I know it's counterintuitive because the first thing we do when we diagnose with somebody is say, don't eat any more gluten, right? And every time you come to the clinic, you come to the dietitian, we check to make sure people aren't eating gluten, and we're checking levels to try to reduce the amount of gluten exposure. But then in a research setting, we said, well, but that's okay. If it's in research, we really you should eat gluten and you'll be fine. And that can feel a little contradictory. But actually it serves a really important purpose. And so what I'd like to start with this is that monitored gluten exposure is safe. What happens in a clinical trial or in a clinical setting, if you have to do a gluten challenge because of different reasons, the diagnosis is not certain, is the most common one. Monitored gluten exposure is actually quite safe. It's the little exposures that cause damage in the intestine and give you years or decades of damage. These are the things that lead to osteoporosis, that cause growth issues if you're in childhood, that can lead to, in severe cases, refractory celiac disease or other issues. It's that chronic, not healed exposure. No gluten in challenge that you do in a monitored setting, in a medical setting, in a scientific setting, where you're having gluten, whether it's a little or a lot, whether it's for a day or a week or a month, none of that is going to cause long-term consequences. It can cause a lot of things, and I'll go through those, but it's not going to increase your risk of long-term complications. And we have a lot of data on that, and I'll show you some of that in a little bit to hopefully convince you of that. There's a lot of reasons for this, but again, gluten has been one of the most important research tools in celiac disease, and it's been used for over 70 years. So gluten, obviously, it's not fun. Oftentimes when people do this, they're doing this very altruistically, and personally, I thank and appreciate every person who's participated in any celiac disease research, but especially those sort of intrepid few who have done a gluten challenge study or a gluten exposure study, and they're slightly different. I'll tell you why in a second. But gluten can obviously cause symptoms, right? We all know that. It can cause GI and non-GI symptoms. So whatever that is for you, when you get gluten exposure, that can happen again. They will cause immune activation, obviously, because that's the way that causes symptoms. They can cause elevations in celiac serologies and small intestinal mucosal injury. But as I just mentioned, gluten exposure will not, in a study, sorry, let me reemphasize that, will not cause an increased risk of long-term complications. It will not cause permanent damage to the small intestine. And ongoing symptoms after the study complete will resolve. And actually, they resolve very quickly. Within a couple of days, usually people are feeling more or less back to normal. That being said, gluten challenge, as much as important as it is, it's not for everyone. And there are some cases that are relatively contraindicated that I, as any clinician, would sort of say, thanks for thinking of it, but actually gluten challenge is not a good choice for you. These are people who are pregnant or are planning on becoming pregnant in the near future. If they have a severe celiac-related neurologic condition, such as gluten ataxia, or if they have type 2 refractory celiac disease. In all of these cases, gluten challenge, gluten exposure should be avoided. basically at all costs. The one thing I didn't put in here that I should probably add, and it's just based on my being sort of adult focused, is children in really critical times of growth and development. So right around puberty, when they're having a growth spurt, also obviously not a good time to have any gluten exposure, especially things that can be controlled. So breaking down, why do we need to use gluten? Well, we have in studies, and there's three main things that we really can't accomplish without gluten in clinical trials. And one is a better understanding of disease biology. The second is development of new ways to diagnose and monitor disease. And three is the development of new therapies. And I'm going to walk you through a little bit of all of these just to give you an idea of what those look like and how they differ, and also what we've learned even thus far. So Jocelyn was nice enough to share her slides with me to make sure there was no overlap. The only place there was overlap in her deck and mine is this slide, which she showed you, which was Wilhelm Dilke's thesis statement. But we're going to use it in very different ways. So Jocelyn quite correctly was using this as a way to show that gluten-free diet in a real world is really difficult. I'm going to use it in a slightly different way to say that this is the reason we know about gluten. Without gluten challenge, without patients in Wilhelm Dilke's clinic, without people who are willing to be monitored on and off the gluten-free diet, we actually wouldn't even know that gluten was the issue in celiac disease. And just think about that for a second. You know, we don't understand a lot about other autoimmune disorders because we haven't figured out what we can add and take back and add and take back. Gluten we have. And so really it's these initial gluten challenge studies that actually defined the disease in the way we think about it today. And everything else we've learned has built off of that foundation. We've been doing this, as I said, for decades now. So these were some other early gluten challenge studies that were looking at small intestinal changes. And these were the first studies that really helped us understand what happened in the intestine with celiac disease, and that it was an intestinal centered disease in the small intestine with the type of damage. And these are two studies that go back, but are really classic studies that we've all looked to. These were sort of giants in the field, Margot Shiner and Dawson, both out of London, doing gluten challenge. Again, these were in both adults and children, and showing not only that you would cause representative damage and helping us understand the biology of disease with gluten challenge, but actually following and then showing that these people all recovered over time. I am going to show you one table, but just because this has sort of been my pet area of passion within celiac disease, is that we've tended to think about this whole idea of non-responsive celiac disease, people not responding as some new phenomenon, and you know, that we're just monitoring more. But even back then, even in the 70s, you can see how many people in follow-up before their gluten challenge had ongoing intestinal damage. So there's been a need for new therapies for celiac disease forever, and we're just more aware of it today than ever. The one other part that I would show is this quote. This was from the Diagnosis of Celiac Disease Guidelines in '79, so it was a little while ago, but you know, in the grand scheme of things, not that long. That said, the only decisive criteria are the abnormal morphology of the small intestinal mucosa, its normalization on gluten withdrawal, and the reaction on reintroduction of gluten. So this reminds us of a time that, again, we're not in these days, and most of us haven't lived through these times, but when every single person diagnosed with celiac disease had to do a gluten challenge, right? And so this is, I think, the clinical data that really convinces us that the gluten challenge in a monitored clinical scientific setting is really safe, because this is the way everyone up through the early 80s got diagnosed, because we didn't have the blood tests that we have today. So what have we learned about how celiac disease works from more recent gluten challenge studies? So the old studies, everyone uses the tools they have on hand. We were able to look at the intestine and show that it was intestinally centered disease with damage that both came and went with gluten exposure. We now have a much more detailed understanding of gluten response. And this is some work that we did together with Boston Children's Hospital and Mass General, and Jocelyn Sylvester was part of this work, where we really looked very carefully at people undergoing gluten challenge and what happened within hours, days, and weeks to really show the progression. And it's taught us a lot. So we took people, everyone with celiac disease, they had the genetic predisposition, and they got a standardized gluten challenge. And what we saw very quickly, and we were not the first ones to demonstrate this, but we certainly corroborated this, is that within a couple hours, people have all these cytokines, which are inflammatory blood markers running around in their blood. So this helps us understand why people get symptoms so quickly, because really within a few hours, in some cases even earlier, of getting exposed to gluten, the immune system sees this and sort of says, whoa, something terrible is going on, and starts releasing all these, again, blood inflammatory markers around. And this is what makes people nauseous and throw up very quickly after getting gluten exposure. But you don't see any changes in the actual cells in your blood that quickly. That takes about a week. And then you start to see these, what we call an adaptive immune response to gluten. These are new white blood cells that say like, oh, there's all this gluten. We got to come and fight stuff in our small intestine. And that change is when people start to have more abdominal pain and diarrhea. And this is what eventually, a week or two later, leads to intestinal damage. So we really have gotten, because people, and again, there's only way to do this is through people volunteering to undergo gluten challenge and be carefully monitored. We really understand the sequence of events. And I'm sure there are still some steps we don't know, but we understand the sequence of events in a very different way than we did even a decade ago in what happens with celiac disease. And I think this gives us some really interesting ways to monitor the disease, to diagnose the disease, and hopefully eventually to even treat the disease. So one of the things I had mentioned before is that, right now, the only real good way we have to monitor celiac disease is intestinal biopsy. And that probably is going to lead to some questions that I'm happy to take afterwards. But obviously, we don't like doing intestinal biopsy, not only because it's burdensome and you have to do an invasive procedure, but also because we only get these tiny, tiny snips of the small intestine. And we try to say, well, so we saw this one tiny snip, and so that must be what the entire intestine looks like. But we know that's not true, right? Medically, we know that's not true. It doesn't even make necessarily a lot of sense. So we are generalizing based on a paucity of data with intestinal biopsy that I think is preventing us from fully understanding and treating more effectively disease. And so one of the things that these recent gluten challenge studies have done, as we've understand the pathway more of gluten, is be able to think about what other technologies we can bring to bear to help us understand how well controlled the disease is without doing an endoscopy. And I don't think we're there yet. It's probably going to take another 10, maybe longer, maybe 20 years. But I do think that the days of endoscopy and small intestinal biopsy being the gold standard for celiac disease are probably numbered. And I think we have other really good tests. We have video capsule endoscopy. So this is a camera on a pill that you swallow, and it takes pictures throughout your small intestine. And that's some really interesting work that's been going on across the world, really, and trying to understand how best to use this in celiac disease, because that can, not only is it just a pill that you swallow, so there's no sedation, there's no biopsy, but it can give us a picture of the entire small intestine, not just the very front that we look at with an endoscopy. We also are using the information from that slide I just showed you to look at these gluten responsive T cells, these special white blood cells that attack in celiac disease, and to look for them in the blood. And to try to understand if that's a correlate, if we can use that to understand how well controlled people's disease is, and also to understand why some people are so sensitive to gluten and some are less. It may just be, it's again, a theory, we haven't proven it yet, but I think it's not unlikely that different people for different reasons just have different levels of these gluten responsive white blood cells, these gluten attacking white blood cells. And if you have a lot of them, you're probably a lot more sensitive to gluten than if you have a few of them. So how might this change, today's clinical care, or the near future clinical care? And so this came up again already from the end of Dr. Sylvester's talk. But how do we use gluten challenge in the clinic, and how long should it be? And so I wanted to use this this algorithm. This was the recent-ish guidelines for evaluation of uncertain celiac disease. So if somebody comes into the office, they say, I think I might have celiac disease, but I've been on a gluten-free diet for a while. Can you help me figure this out? Which is actually pretty common. This is what we're supposed to go through. And we start with a baseline serology, tissue transcontaminase. If that's positive, then people probably are not as gluten-free as they think they are, and you can go ahead and proceed to intestinal biopsy. But more commonly, they're negative. And in these cases, we'll go through this sort of long and challenging train of steps where first we'll do the genetic testing to make sure they're DQ2 or DQ8 positive. And if they're not, they will not have celiac disease, and that can be the end of that workup. But if they are, then we do the gluten challenge. And then there's been a lot, and I actually think these are a little outdated in this way, because it says 3 grams of gluten daily for 2 weeks. and then potentially is able to continue to go on to intestinal biopsy. I actually think this is a little short and or a little bit low gluten, so you can either do more gluten for that time or that amount of gluten, but it should probably be longer to have a better diagnostic test. But as it says here, it sort of has an out. Patient able to continue, and I really do in my clinic push people to at least have 4 weeks of 3 grams of gluten, which is about maybe 1 or 2 slices of bread, depending on your bread, just roughly. But a serving of gluten a day for up to additional 6 weeks. So I try to get people to do 4 weeks to have the best chance of really making a conclusion. And then go for intestinal biopsy and serologies. And if these are positive, they have celiac disease. And if you have a discrepancy, we have positive serology and negative biopsy, then you have this unclear and you have to sort of go around the circle again, repeat some more blood tests. So it's really not a great algorithm. It's a lot of work for patients and clinicians. And obviously this is a lot of people just say, you know what, forget it. I'll just stick with the uncertainty rather than go through all this. The other issue that comes up even more frequently these days that I think is worth pointing out is that a lot of diagnosis now is being made based on blood tests alone without intestinal biopsy. And that in some cases is perfectly appropriate, but I think it's overused. And I think oftentimes the standards for how to use a biopsy-free diagnosis are not well followed, leading to a lot more of these uncertain celiac disease patients. People have mildly positive TTGs or something like that, and no additional data to suggest they have celiac disease, and then being put on a gluten-free diet. So this is where I think we may be heading. And actually, you can make a claim that this actually could be something that is done for almost everyone and not just people with equivocal celiac disease, is that instead of going ahead and doing this long, month-plus long gluten challenge, that with these new tests, with the data that we've learned from these gluten challenge studies, is that in people with the right genes, that's still an easy way to start, that a single dose of gluten, maybe 3 days at most, should be plenty to give us all the information we need with the cytokine response, these fancy things called tetramers, flow cytometry, which is another fancy sort of way of looking at different blood cells that may be specific to celiac disease. And that should really be all we need to tell. So imagine going from 1 month of everyday gluten plus an endoscopy to just saying, God, just take gluten once and we'll do a blood test and we'll know. That's the kind of sort of step forward in celiac disease care that we're all looking for. And I think that makes this all so exciting. And in this case, only if you have those few equivocal cases, because in medicine, biology is complicated, there's always equivocal cases, then maybe you'd fall back on the old algorithm. But I think based on what we're seeing in the early literature, 95% of people would probably fall into these positive or negative categories, and only a very small number of people for clinical reasons would have to do these long gluten challenge. And I think that will help a lot, because then the barrier for understanding, yes, I really have celiac disease, is so much lower, right? And so hopefully the rates of misdiagnosis in both directions, right, go down significantly. So moving on to clinical trials and of new medications. And I wanted to start with a really nice quote I got from a patient a little while ago. And she says this, she said, studies with gluten put more burden on patients, and investigators need to have the knowledge and resources to help with any issues. However, as much as I really didn't love having to eat gluten for the study, I don't think I would really trust the results of a study without gluten, since I wouldn't know what it was treating or how much it would protect me from. So this was in specific in the setting of a clinical trial for a potential new medication for celiac disease. And so, I thought this was great, and I'd love to hear comments about this quote, because I really think it's important. We all want the security of knowing that a drug that we use in celiac disease, a medicine we use in celiac disease, will really protect against gluten and how much it will protect from. But if we want that and we feel that's important, then people are going to have to eat gluten to test that. And again, this is something that we wrestle with, and I think it's something, how to use gluten as appropriately and responsibly as possible is really a work in progress. So part of the reason I think we need to do this is because we've learned a lot about how to do clinical trials in celiac disease of new medications, and this section will be mostly based around testing of new medications for celiac disease. We actually have a really good track record of looking at of taking mouse models of celiac disease. And so mice that have been genetically and otherwise sort of made to have things similar to celiac disease, looking at if a drug works in that disease, in that model, and then seeing if it works in patients. And this, we have actually a remarkably good, in the scheme of medicine, track record of showing that if it seems to work well in these celiac mice, it actually does something useful, and it seems to do something useful in people. But when we've tried testing this in these therapies in the real world, we've had challenging results. In the studies that have taken people, to give a little more detail, who have taken people who are struggling on the diet, right? And I think this is where we all see a lot of need in the clinical community for celiac disease treatments, is for people who are really struggling. They are trying the gluten-free diet, but for whatever reason, be it socioeconomic issues, be it just work-life issues, they're not able to remain gluten-free enough to keep themselves feeling well and with intestinal healing. And so these are the people we've tried to treat in a couple of different studies now of new medications. And what we've seen is that not only do maybe the drugs seem to help people get better, but the people on placebo get a lot better as well, largely because they're in this clinical trial and suddenly they're getting tons of reminders about celiac disease, they're getting more clinical visits, things that don't happen in real life. So the amount of gluten people get exposed to in a clinical trial is much less than they get exposed to in real life. There's also some other issues about it being very difficult to confirm that people with ongoing symptoms are due to gluten and celiac disease. And Dr. Sylvester mentioned this earlier, right? Just because you have celiac disease doesn't mean you can't have something else. And that's confusing. Misdiagnosis I've just talked about. And one thing that's just maybe more of a factoid for everyone is that histology, that the amount of damage in your small intestine, does not really correlate well with the amount of symptoms you have. So some people have severe symptoms with almost normal intestine, and some people can have terrible looking small intestine, but really have no symptoms. And I see those people in clinic all the time. So we've talked a little bit about this already, so I'm just going to hit the highlights of this. Is that, you know, I think, you know, again, we can talk about this, but one of the things that that most of us in the clinical field and scientific field believe is that really understanding what happens in the intestine is really key to understanding if a therapy has value. So controlling symptoms is important, and that's what people experience and have the burden of on a day-to-day basis, is having ongoing symptoms. But in terms of really managing the disease and preventing, hopefully, long-term consequences of the disease, it's really looking at what's happening in the small intestine that's most important. So there are two main types of trials in celiac disease therapeutics. One, you know, in the big buckets are early trials and late trials. So early trials are you've got something it's just coming into clinic, and you just want to know if it works at all in celiac disease, if it has any potential future. And the easiest way to do this, the most definitive way to do this, I should probably use that rather than easiest, is to do this gluten challenge study. So this is taking people with well-controlled celiac disease and giving them the drug and some gluten and seeing if the drug can protect against the effects of gluten. In later trials, we're doing something sort of different, where we're taking people with active, poorly controlled celiac disease, as I mentioned a second ago, despite their best attempt on a gluten-free diet, and trying to make them better. And so that's obviously where we're going, but that's there's a lot of challenges to that late trial, so we usually progress in this way. Gluten challenge in the beginning, treatment trials later on in development and testing of therapies. So one of the things that's happened in the past is we've gone from gluten challenge studies, where we give people these large doses of gluten for well-defined, short to medium amounts of time, anywhere from a few days to a month or so. And then we've moved to these trials where we don't give anyone any gluten and just try to make them better. And again, this has led to a lot of complexities in what we understand, and I think some missed opportunities with medications. But as we've learned more, and thanks to the work of Justin Sylvester and others, and who have really dived into what actually is gluten, what is a gluten contamination in a regular diet like, we can start to try to model trials to reflect that. And I think this is really changing the way we think about clinical trials in celiac disease. So what do we know about real life gluten exposure? And I think this is important, and it touches a lot on what Dr. Sylvester talked about, but maybe with some different perspectives. So what do we know? That despite education and best attempts, gluten exposure happens, and it happens to everyone if you give them and if you follow them for enough time. It occurs in all countries, right? So this isn't an American problem or a Canadian problem or a Spanish problem. This, everywhere we look, everyone gets exposed to gluten. We have seen that gluten exposure in young children actually is pretty rare. They have a pretty controlled diet. They're not getting out and doing business trips and the like. But it goes way up in adolescents and adults, as you would expect, as people are out and about in the world more often. Exposures are intermittent and occur at variable frequencies. And the amount of gluten people get exposed to varies significantly. So they can have little exposures, big exposures. So we can try to emulate that, and I'll show you how in a clinical trial setting, to try to understand better if a medication would help people in these real life gluten exposure situations. That being said, I think this is still an area where we need a lot more work. We need better estimates for the frequencies of exposures, and better estimates for the amount of exposures people are getting on an average basis. I think we also don't know almost anything about regional and seasonal demographic sources of variation, right? So we've done a few studies in a few countries, but does the holiday season look different than the summer? Does do people with higher or lower socioeconomic status have the higher or lower rates of gluten contamination? These are all things we really should understand to understand how to improve our teaching about the gluten-free diet, but also to improve our understanding of how the gluten-free diet can be augmented potentially with other treatments. So these are what these studies look like. So the gluten challenge study, this is what most people are probably familiar with. And it's based very much on what we do in the clinic. High dose gluten exposure, so 3 to 12 grams per day, 2 to 8 slices of bread per day, with the aim of making the disease worse, right? We can't diagnose celiac disease if nothing changes. So this is exactly what was done in the 70s and 80s with everyone as part of diagnosis. We just use it now for research. It's not part of routine diagnosis, although it is still part of that equivocal celiac diagnosis, as I showed you in that algorithm. So we can use this to study the pathophysiology of celiac disease and really for early trials to see if drugs might be effective in protecting against gluten. The newer type of trial, which I think is just coming into its own, is what is right now termed simulated inadvertent gluten exposure. Sometimes the acronym is SIGE or SIGE sometimes. And this is defined as intermittent low gluten exposures, a couple hundred milligrams of gluten a couple times a week. So we're really trying to say, like, we kind of know what happens on average in the real world. Let's make sure that's happening in our trial, so we can make sure that whatever we're studying, whether it's a drug or a dietary intervention or something, really applies to people in the real world. And I think this is really can be really potentially helpful in understanding the impact of real world gluten exposures and looking at drugs to help protect against those. And this is just the same thing showing in a different, more visual format, but gluten challenge styles, short, but a lot of gluten. Gluten exposure studies are much longer, usually 6 months, maybe even sometimes longer, but much, much lower gluten exposure. So cross-contamination level type gluten exposures that happen intermittently throughout the week, and ideally should be part of food versus just the sort of gluten slurries that are sometimes used in the gluten challenge studies. In the gluten challenge studies, we look at worsening of intestinal damage in the clinical setting, right? I mean, that's how we diagnose celiac disease, if the intestinal biopsy worsens with gluten exposure. In a gluten exposure study, however, we actually look at improvement with a drug, improvement in signs and symptoms of celiac disease, despite this ongoing small amounts of gluten. So just wanted to sort of introduce those because they may be things that you hear about, that you see advertised in upcoming clinical trials. So I think it's important to understand the background. I just want to sort of go into the rationale for using these low sort of cross-contamination like or cross-contact like gluten exposures in a trial a little bit more. This was a study, the graph on the right here was a study that was done out of Argentina, a big celiac center, where they monitored people. All they did is ask people to monitor stool and urine for gluten. You've seen these technologies already that Dr. Sylvester presented, and doing nothing more than just saying, we're going to collect stool and urine, no surveys, no intervention. The gluten exposure went way down in the beginning and then slowly crept up over the first month. So we know that any intervention will cause people transiently to reduce gluten exposure. And I think not having any gluten in a clinical trial of a new drug gives us two important risks. So one risk is this top one, that a therapy is effective against a reduced amount of gluten that people are exposed to in a setting of a trial, right? So people go on a trial and they reduce gluten exposure, as we saw in this study here. And a drug looks like it works, but it really only works against such teeny amounts of gluten that once you put it in the real world, it's not effective anymore. And so the result of this is a medicine could be approved, but later found really not to be effective. On the other hand, there is the risk that a therapy could be ineffective in a trial, as once you reduce all this gluten, residual symptoms, leftover symptoms that people still have, might not be due to celiac disease at all. And so a drug might look like it has no effect, really because it's not the people who are still in the trial having symptoms or have another food intolerance, they have lactose intolerance, they have irritable bowel syndrome, they have ulcerative colitis or some other undetected issue. And so the result of this is a drug might not be approved, even though it could have really significant benefits in celiac disease. So I think there's an important role for you continuing to use gluten in celiac disease clinical trials, really so we can really inform everyone, the clinicians, the scientists, the patients, most importantly, here's what this drug does, here's what it doesn't do, here's how much gluten it might seem like it can protect you against, here's how much it just is not going to be able to protect you against, so that people can make it really the most informed decisions about if and when and what medication could be helpful for them. So there are some issues with gluten exposure, and the first one is the point that I think is most important for this audience, is that it's slower enrollment, right? As I said in the beginning, everyone is enthusiastic about celiac disease, especially when somebody else does it. A little bit less so when they're asked to participate in something burdensome, and a lot less so when it includes gluten. And this is a really a key issue. And so really, I think the solution, and yeah, for other ideas, but partnership and hopefully education such as this, but partnership with the patient advocacy groups, such as the CCA, to provide advice on study materials and recruitment strategies and really help educate the population about why this is being done and why, how to make sure that it's safe and everyone's well informed so they can make educated, informed decisions about whether and when to participate in trials. We also have to keep an eye on gluten doses. It's very easy, and we've seen this in some trials where people sign up for the gluten challenge studies and then after a day or two, they forget this, I'll continue the trial, but I'll stop taking the gluten part. That is, obviously you can stop a trial at any point, but that if we're not aware of that as an investigator, it can make the results very hard to interpret and can lead to some issues that are very hard to then sort out and correct later. Dropout can always happen, but I do think that site and investigator training, and this is what that patient quote, a lot of what it said was, we need to do a better job, I think, in the community of not only helping patients understand why gluten challenge might be effective, but helping sites and helping investigators know how to treat patients if they get very sick, if they have questions, really how to be more proactive about managing gluten exposure. And of course, we need better standardization of gluten amount and form so that we can learn from all these clinical trials and apply lessons from one trial to the next. So getting close to the end, so I just wanted to go back to potential paradigm, this use of how to use gluten and when in clinical trials of therapies. So in therapies, we usually progress through these 4 stages. So phase 1 are small studies just for safety. Phase 2 studies are really where we really understand if a drug is biologically active. Phase 3 studies are the big studies that are used for approval. And then phase 4 are things that happen usually after the drug is approved to really understand its real world effects and make sure it's doing what we think it's doing. And importantly, is safe and not doing anything we don't think it's doing. And I think these 2 middle phases are really going to be important for gluten exposure to continue to be used so that we can provide everyone with the confidence in a drug should it be approved. And if it's not approved, if it doesn't seem to be effective, we know why. So conclusions, gluten exposure is a vital tool in celiac disease research and therapeutic development, but really, when and how to use it requires careful consideration. And one message that I do want to leave is, no one in the medical or scientific community undertakes a gluten challenge study, writes up a protocol for gluten challenge study lightly. We all think very carefully about if we need to do it, how much, and try to, whenever we do need to use gluten, use the minimal amount for the shortest time possible. Gluten in a monitored setting, clinical setting, can be uncomfortable, obviously, but it really is safe. You'll see different gluten challenge types used in different studies, and I think this is appropriate. But in the clinic, I'm really hoping that these long gluten challenge studies, long gluten studies to understand whether somebody actually has celiac disease, will not be the rule going forward, where, as I said, it's going to be a few years, I think, until some of these things really get to prime time. But I think these long gluten challenge studies that we've been doing, for 70 plus years, really will soon be a fallback strategy for difficult cases. And in clinical research, I'm not going to read this out to you. I'll leave it up. But I really think that it's just important for people to understand that, why we still do gluten challenge and how important this really is for the future of celiac disease. So with that, yep, that was my last slide. And, Mark, I'll hand it to you and whatever time we have back for questions.
Thank you very much, Dr. Leffler. That was a fabulous presentation. I really appreciated you opening it with the importance of participating in research studies and why the gluten component is so critical. And the patient quote was also very helpful. I totally agree. Understanding that it's not for everyone, but those who are able, please participate in research studies. You can sign me up. You got my email.